Hello everyone, I'm Rachel Lowe from Physiopedia. Today I am talking to Eoin O'Connor. Hello Eoin, how are you?
Hi, thanks Rachel.
Good to be talking to you again. We've worked together before on some video projects and things like that. It's nice to catch up with you, and today I'm hoping to talk to you about the shoulder. But before we delve right into the shoulder, perhaps you could just give everyone a little introduction to yourself to let them know who you are and what you get up to if they haven't met you before.
Okay, thanks Rachel. It just seemed like quite a long time ago that we worked on those video projects. My name is Eoin O'Connor. I'm a physiotherapist specialising in shoulders and upper limb problems. I qualified in 1999, and I suppose I've had a journey of different experience through public sector, private sector, NHS, big teaching hospitals, sport, and worked for quite a few years as an extended scope practitioner, doing triage and injections and ultrasound guided injections. And about 5 years ago, moved back to the west of Ireland, set up a clinic, evidence-based therapy centre. And it was, I suppose, I was missing rehabilitation with patients. I think working as an ESP, it was a fantastic experience to do lots of assessments and develop lots of, pattern recognition skills and diagnostic triage skills. But I was really missing that time spent with patients. And I've gotten my rehab mojo back in the last 5 years or so, working very closely and building up clients to improve their shoulders and reduce their pain.
So do you see just shoulder patients at the moment?
No, I do see everything, and I think it's really good to see everything, and to keep my skills up across the whole spectrum of musculoskeletal and sports and chronic pain. But I suppose about 75% of my caseload would be shoulders, or they come in with pain in the shoulder area. It may not end up being from the shoulder, but about 75%, I would say.
Okay, so I'm interested to know, out of those shoulder patients that come and see you, what kind of shoulder presentations do you see?
Okay, well, I suppose I think about shoulders in different categories. I suppose the biggest category, which makes up probably in the region of 50% of all shoulder pain, is rotator cuff related shoulder pain. So I think probably between 50 and 60% of my caseload would be rotator cuff related. Probably the next category would be the restricted or stiff shoulders, mainly frozen shoulders. And I would say 15 to 20% of the shoulders that I see would be of that presentation. Instability and hypermobile shoulders would be the next category. And, they're variable really. A lot of them will go to specialist centers, and it may be as few as 5% of my caseload are instability, but at times it might be higher, particularly around the sporting season here in Ireland, when there's lots of traumatic dislocations. And then the rest is made up of, a mixture between ones that aren't really a shoulder, or very mixed presentations, that have more unusual presentations like nerve palsies, long thoracic nerve palsy, or spinal accessory nerve palsy, very unusual ones, maybe rheumatological presentations. And then of course ones that I might categorize as, the dominant presentation is not necessarily the fact that they have pain in their shoulder, but the fact that they have sensitization and chronic pain, and that is the dominant feature. So that, I suppose, reflects what I see.
Yeah, and I'm guessing that what you see is a reflection on populations, probably as well.
In a primary care setting, a first contact setting, I think that would be fairly standard.
Okay. So you have these three main groups, and then a few other random classifications or sort of categories. How do you differentiate between those?
Okay, I think the first thing really is to very closely listen to the patient. I think often they tell you, even before I lay a hand on them, before I do any physical testing procedures, we let the patient speak and really explain their story, tell their story. And I'm just trying to actually find out, what do they need from me today? What is their main problem? And, I suppose what I've learned as I've become more experienced is to try and actively listen more, to really listen to what they're telling me. And often the diagnosis is almost there, generating the hypotheses about what might be the problem. And then you can do a limited number of tests to try and test those hypotheses. I think there's a really nice clinical reasoning model from Jones that I use, called the collaborative clinical reasoning model. And it's really about how we're, as therapists, as clinicians, are going through our clinical reasoning. When we're asking the questions, we're getting that knowledge acquisition, then we're thinking about that and generating lots of different hypotheses about what the problem might be, maybe asking more questions to try and refine, is this a shoulder? Is this maybe a neck? Is this something else that might be more serious? Asking the red flag, serious pathology type questions, and gradually narrowing down our hypothesis to, one or two or three things that we really think might be most likely, and, having a few testing procedures to try and test that. But at the very same time, the patient is going through their clinical reasoning in a slightly different way. They're listening out to what you're saying and the questions you're asking and the tests that you're doing, and they're having a growing understanding of what might be the problem. So I really like to think about the patient's journey through their understanding as well, right from the very start. We have to be, I think, careful with our language and the words we use, that we're not scaring them and provoking anxiety, and that they're really broken or something really badly wrong with them. So I do place a really strong emphasis on the interview part, or the subjective examination, or whatever we want to call it. And then in my model of shoulders, where I'm thinking stiff shoulder, weak shoulder, which is the rotator cuff category, wobbly, hypermobile instability category, or serious pathology, rheumatology, or the other ones, I really try and have some good simple tests that try and test that, and that are very understandable to the patient as well, that you can explain as you go along what you're doing.
What are those good simple tests?
Well, active range of motion testing, passive range of motion testing at the heart of it. And, I think these are sometimes skipped over. I absolutely feel so strongly about this. And a lot of my courses, I notice this, that it is a big shock to some physiotherapists that for passive range of motion testing, I'm insistent that you get the patient on the bed. And I think that is absolutely important. So I would do active range of motion testing in standing, and I would get them on the bed and do passive range of motion testing lying on their back, get them truly relaxed, really try and do a true movement without them joining in, explaining that I don't want them to join in, I don't want them to help me move their arm, I don't want them to resist me moving their arm. And I'm checking that difference between active and passive. And I think that they're the heart of it. I think we learn an awful lot simply from looking at active versus passive. And then rotator cuff testing, again, I'm very keen on doing this in lying on the bed. I think if we do resisted testing and standing, I think we know we're not isolating the rotator cuff very well. So I'd always do through range testing into external and internal rotation lying on a bed. And sometimes I stop there. Really, sometimes I have my diagnosis at that stage without doing lots of different fancy tests with eponymous names, that often have fairly poor reliability. Obviously, if the indication is there to do neurological examination, that can be very important as well. And to help differentiate from the neck, I might want to examine the neck as well. But I think those three key areas are the major ones to do really, really well.
Okay, so that's probably seems to be quite a small or short assessment to some people who have learnt lots of specific tests, lots of other ways of examining, doing the objective examination or the physical examination to a patient. Excuse me. How does someone develop those really good clinical reasoning skills so that they can be really specific in their testing or while they're working with the patient?
Yeah, that's a really good question. And, I think the short answer is, with time, you do need to have mileage really and experience to develop the pattern recognition. But I think we can really improve our pattern recognition and our patient mileage by doing lots of reflection on what we're finding. So clinical reasoning sheets, I'm a big advocate of those. So filling in these, going through this yourself or going through with a peer or a supervisor, and really reflecting on what you are doing, and getting somebody else to watch you doing an assessment, and to feed back to you. Video assessments, absolutely fantastic. Really, really scary, to see yourself for the first time assessing a patient, but you learn so much from it. I remember the first time I ever had a video assessment done on me, and I noticed some absolutely terrible mannerisms that were just, I was asking the patient these really long questions and looking at them a little bit too intensely. And I learned an awful lot from that. So I think if we can do less in the physical examination, spend more time getting to know the patient and listening to their story, and then also having lots of time to unpick it, to reflect on it, and then to unpick it with the patient and discuss with them, what your findings are, and to discuss what the treatment options are, and develop a collaborative plan with them. So that's what I like to use my time for, really, rather than doing lots and lots of tests.
Yeah, okay. So your assessment is very based on communication, asking the right questions, spending time understanding the patient, which is all very important. It is very important, and we need to have those good skills, as well as a few simple tests that you are able to then start to recognize patterns that you've seen with all the experience that you've had in those shoulders. Are you able to share some of those patterns for the categories that we talked about at the beginning?
Okay. So the stiff shoulders, a frozen shoulder, I suppose my pattern recognition would be thinking about somebody with the right age for a frozen shoulder. So between the ages of 49 and 62, the literature tell us. A peak age at the age of 52. In Japan, they call it the 50-year-old shoulder. And if they're coming in with quite severe pain, often waking in the night with pain, I'm starting to think, oh, I wonder, is this a frozen shoulder? And they might tell me activities that are painful, like anything lifting their arm above 90 degrees, washing their hair, touching the back of their head. And I might ask more specific questions to really probe and think whether external rotation might be a problem. Classics for me, I suppose, we have a lot of car parks in Galway, and if you have a right frozen shoulder, putting your ticket or taking your ticket out of the car park machine as you drive in is incredibly painful. Or switching off the bedside locker is another external rotation and abduction movement that I would be probing with. And would really start to build up my index of suspicion that this is looking like a stiff, restricted frozen shoulder. Waking in the night is something that is often a problem for people with a range of different shoulder conditions. But in the early stages of frozen shoulder, I think it is probably one of the most prominent ones. So I would be making sure that I'm doing a really good passive range of motion assessment then, and planning that into my assessment. For the weak shoulders, rotator cuff, probably a similar age group, maybe starting a little bit younger. We know the tendinopathy zone is anything from 40 years of age or slightly older upwards. Maybe a more grumbling type insidious onset, maybe after a period of using the shoulder more than usual, something new and unusual for the rotator cuff tendons could cause them to react and be painful. Perhaps activities again above 90 degrees, but more repetitive activities. I'm starting to wonder whether this might be something up to the rotator cuff. Instability patients and hypermobile patients. Well, I think often they'll tell you that they've had a dislocation. That's kind of easy, but sometimes they are a little bit more subtle than that. And I think there is a range of complexity that we can go into in terms of the different types of instability. But I would like to make clear that I think that we have to be very clear of the difference between an unstable shoulder and a hypermobile shoulder. And they're both in the same category, really, for me, in my model. Your unstable shoulder is the one that is at risk of imminent dislocation, or has had a recent history of dislocation, may dislocate again soon. Whereas your hypermobile shoulder, yes, it moves around much more than the average shoulder. Maybe that increased movement and laxity around the shoulder is causing their symptoms, but they're not in danger of dislocating. So I'm quite clear on the semantics there and the language that we use. I think, pattern recognition in terms of red flags and serious pathology, there's a lot of work done on this, and I direct people to do the reading on this, because we all need to know this, whether you're seeing shoulders or whatever you're seeing. But sometimes it's things that don't add up, and I think particularly, I would be always particularly careful with what looks like a frozen shoulder. So if we have a restriction in the shoulder, we do need to be careful that restriction is because of a capsular problem like a frozen shoulder, and not because of something more serious, a space occupying lesion, a bone tumor. And there have been a number of really good case series published where they show that there can be up to 3 or 4 of these cases per 1,000 patients in a consecutive shoulder clinic that actually have a bone tumor that's restricting their movement rather than a frozen shoulder. So in my opinion, if they have a clinical presentation of a frozen shoulder, they should go and have an X-ray. We should probe a little bit deeper on our serious pathology questions.
Are there any other red flags that are sort of more specific to the shoulder region?
We don't have lots more, really. Pancoast tumor is, I suppose, one that it does sometimes present as shoulder pain. It is very rare. I've never personally seen one, never come across one. Lung cancer, primary lung cancer can be, sometimes even the first symptom of that can be shoulder pain. And I have come across a couple of those over the years. So, I mean, they cover the usual red flag type questions that we might ask anyway, in terms of cancer and weight loss and loss of appetite and things like fever, night sweats, and fatigue and persistent cough and all the things that we should be screening for anyway in all of our clients. It's not necessarily a place for a secondary metastasis that you would think of immediately, but you can get primary bone tumors in around the neck of the humerus and the head of the humerus. And I suppose working as a physiotherapist and then working in an orthopedic unit and working in orthopedics, I kind of became quite acutely aware that when you start to image lots and lots of people, you do start to pick up more of these than I thought existed. So the stats are that probably about 1% of the patients coming through will have some pathology that might be serious pathology.
Okay, so and for those patients, obviously we're looking out for those red flags that and the things that you've mentioned, as well as everything else on the red flag questioning that we do, that we all know, and that that you can look up quite easily. There's plenty of stuff written about that everywhere. You mentioned imaging. Where does, just before we move on to some management strategies, where does imaging fit into this picture? When should we do imaging? When is it appropriate? When is it effective?
Okay. It's a hot topic at the moment, and I think imaging can sometimes be really, really helpful in our differential diagnosis and in planning the management of a patient. And it can often actually be really disruptive to our clinical reasoning and our management of our patient. And I think that we shouldn't necessarily be making our clinical decisions based on what we see in imaging as a general rule. It should be about the collaborative decision with the patient and weighing up their symptoms with what the management strategies are. We know that there is some incidence, as I said, of serious pathology in what appears like a frozen shoulder. So that is one group that I would say always need an X-ray, without fail. I think with the rotator cuff group, we know that there's quite a poor relationship between the presence of a tear or the size of a tear and the presence of symptoms. So I think we need to be quite careful about imaging for rotator cuff and be quite careful about our interpretation of the findings of any imaging, whether it's an MRI scan or ultrasound scan. And actually, more importantly, we need to be very careful of the interpretation of the patient of the findings of that MRI scan. So I'll often, in Ireland, there is huge access to MRI scanning. A lot of people have private health insurance and will seek out a scan and get a scan for their shoulder pain. And I have many patients come in clutching their CD-ROM with their MRI, MRI results in there, and they'll come in and they'll always say to me, "Listen, you don't need to do an assessment on me because I've got my scan and I know there's a tear, so can you fix that?" And I then may go and I would assess them, take their history, and they might be getting a little bit impatient with me because I'm going through all these things and all the information is in the scan. And I assess them, and then they have a frozen shoulder. And their MRI scan shows that they have a tear in their rotator cuff, and we know that maybe up to 50% of people age 50 have a tear in the rotator cuff. But their dominant presentation, the reason why they've got pain and the reason why they got loss of movement is the frozen shoulder. And that's sometimes really difficult to unpick with the patient. So in those cases, actually the fact that they've come to me with an MRI scan result means that there's a big mind shift for them to come through. So you're saying that it's nothing got to do with the tear in my tendon. Are you sure about this? So I think that's an important consideration. I think that the decision whether or not physiotherapy is appropriate for somebody with a rotator cuff problem is not necessarily made by the scan results either. I think the level of symptoms or their response to initial therapy is probably the best way of making that clinical decision. But if we're unsure, if we're worried about serious pathology, or think things aren't adding up with a rotator cuff related problem, then I think an MRI scan can be a good option. I think the most nuanced group for scanning is probably the instability group. And by nuance, I suppose I mean that open to a lot of interpretation and needing quite a lot of expertise around interpreting the results of that scan. So somebody with a traumatic dislocation, really we probably do want to know as much as we can about what structural damage has been done. what is the status of the glenoid labrum? Has there been any bone loss around the glenoid? Is there a sizable Hill-Sachs lesion? Has there been, the head of the humerus, is there a bite out of that? What is the status of the glenohumeral ligaments? And although we can get a lot of information from our clinical examination, some clinical testing for that, I think if we're going down the route of referring for orthopedics and surgery, we certainly would need to be thinking about MRI scan or sometimes arthrogram to look at the labrum in more detail for that group. So overall, I suppose they would be my general thoughts. I'd like to think that we as physiotherapists are in a position to try and stop the MRI scan in particular becoming an additional barrier to recovery. Because sometimes if a patient believes and thinks that they've got something very damaged and very broken in them, they have negative expectations. And all of the information and all of the research recently, particularly say by Rachel Chester's PhD work, shows that probably the strongest predictor of somebody's response to physiotherapy is their expectations of whether or not they're going to do well or not.
Yeah, absolutely. Yeah, and I think there's going to be more conversations about that in the future, about expectations and things like that. It's a very good point, and that's something that, coming back to what you talked about initially regarding communication and that talking to the patient, then that's where we have to manage expectations as well. I'm all the way through the assessment and the treatment. So moving on to, unless there's anything else that we've missed with regards to assessment, can we move on to management strategies and your thoughts on how we, I'm thinking that we'll talk about each group separately or as a different kind of approach to each group. So what are your thoughts on that?
Okay, a whistle-stop tour. Okay, yes. this could be a very big conversation, but we'll try and summarize, I think. So the first group, the frozen shoulders. So I think probably one of the most useful bits of kit. I think the most useful bits of kit that I have in my clinic is my whiteboard, and I will spend considerable amount of time with my patient, explaining what their diagnosis is, going through frozen shoulder, what the pathology is, what the course of the condition is, how it goes through various different stages, from a very painful stage to a stage that's more dominated by restriction, and how it will probably resolve over a period of time. But this may be a long time. Talking about how the diagnosis is made, how I'm confident that this is a frozen shoulder, justifying why we need an X-ray to rule out anything else, and really, reassuring them about, that we can't damage a frozen shoulder. We can do what we want. It may hurt, but we're not going to make it worse, whatever we do. And then it's, a really big discussion about what are the different treatment options. And in my mind, there's probably five different options for patients with frozen shoulder. From most conservative to least conservative, we have do nothing or supervised neglect, as it says in the literature. And that's not palatable for most people. It's a pretty miserable, horrible condition, very painful and disruptive to their life. So, but some people will choose that, and that's I would support that. But taking them through, the next most conservative would be physiotherapy, exercises, some manual therapy, some stretching. And I would usually suggest that this is probably not beneficial in the very early, very painful stages. And I think, there are a few studies showing that, unless it's quite a mild frozen shoulder, if it is in the very painful stage of frozen shoulder, probably we don't make much difference really, other than maybe, the patient's not liking us very much. I think it's choosing the people to intervene with, really. I think it really comes into its own as we move towards the more restricted phases of frozen shoulder. that we can really work with the patient to get that range of motion back and to get that function back. Option 3, I think the treatment of choice, if pain is very significant, if there's resting pain, if there's waking up in the middle of the night, is a corticosteroid injection. And in my opinion, it should always be guided. It's a deep structure. To guide it into the right place is quite difficult. Even, from my experience, in some people, when you use ultrasound to guide the needle in, it can be quite difficult, to get to the right point in the humeral joint. But most people will get really good relief in their symptoms from a steroid injection, and talking through the pros and cons and the risks and the benefits for the patient for that. If we're going up the chain a little bit more, arthrographic hydrodistension or hydrodilatation. So it's like a big injection. I describe it to my patients, where you put in some local anesthetic, perhaps some steroid, and then some sterile salty water to stretch the capsule from the inside. And usually 2 of those about a week apart can give good improvements in range of motion and pain. And again, talking through the pros and the cons, risks and the benefits with the patient. Manipulation under anaesthetic is still alive and well in the west of Ireland. I don't necessarily think it's the best approach for this, but some patients do get good relief from it. I think it's quite invasive when we have lots of other options. I do talk about surgical release of the capsule as well, which can be needed as well. I think particularly if other things haven't worked. But as a strong advocate of more conservative measures for shoulder problems, I suppose I put my hands up and say my bias is away from surgical intervention for this condition. So yeah, I think a big part of our treatment is actually just talking through the range of conditions, and even if it's really clear, what is probably the best treatment for them, and just to make sure that they're opting into that. And I will always discuss that with the patient. So where do you think you are on this list of things? What do you think we should try first? And having a really good chat to them about that, and then actually, what is the commitment? So if you choose physiotherapy, what's the commitment? And again, getting them to commit to that. Saying, are you up for this? You're going to have to do exercise, a couple of times a day, for a minimum of 6 weeks, probably more like, 12 weeks and longer. Are you up for that? And, just asking that question and waiting for the response, not assuming a response, I think is, again, a really important part of the treatment right across the spectrum of shoulder problems.
Yeah.
And I would go through similar with rotator cuff related problems. Probably it's simpler 3 different strategies. Is it, physiotherapy versus injection versus surgical intervention? And talking through again, how we're going to build up the shoulder if we're going to do physiotherapy. And I think really there it's making them aware that, it's almost like graded exposure, I think, with rotator cuff, that in the initial stages is about building the tolerance levels of the tendon to the activities that they're having problems with. So really trying to boil down the things that are important to them. What are the things that are making it sore, and try to make their exercises very, very relevant to those activities, so they can see very clearly, okay, this exercise is for my difficulty with washing the windows, or whatever it is, and talking about how over the weeks we're going to actually build the tolerance level of the tendon, that it doesn't react anymore, that it doesn't take in lots of fluid anymore when we use it, but we get it to actually get used to those activities. And I think it's only in the later stages of rehabilitation for the tendon that we're actually really probably changing the structure of the collagen fibers. So I explain all of that. I'll do lots of diagrams on my whiteboard, and maybe talk a little bit too much sometimes, but I think just establishing that rapport in that first couple of sessions, and they're yours then, they're really on board if they fully understand and they fully opt in.
And And the same, I'm guessing, for the wobbly shoulder with
Yeah,
abilities
yeah,
or hypermobilities. Again, physiotherapy, probably not injection, I'm thinking,
yeah,
or
absolutely.
yeah.
Yeah. I suppose the thing about the dislocators, in some ways, it's more straightforward. In a lot of ways, it's more straightforward. And particularly if they've had an operation to stabilize their shoulder, then you have a fairly standardized protocol to build up the strength around their rotator cuff, the strength around their scapular muscles, and their functional ability. If they haven't had an operation and if we're weighing up, whether or not they will respond to physiotherapy or not, that can be a longer conversation as well, and can be more nuanced as well, in terms of trying to predict whether somebody is going to dislocate again or not, and whether we should go to operation or not. And there's a lot of work on this. It's it's a detailed area. As a really quick one is that if they're very young, certainly if they're under the age of 19, they're very likely to have recurrent dislocation, and they're very likely to have to go and have an operation, and then we see them post-operatively.
Yeah.
If we think about the other groups, if we're thinking about the Stanmore triangle, we have the polar type 1s, which are the structural laxity due to trauma. And then we have the type 2s and the type 3s. And the type 2 is, some structural laxity, but they're atraumatic generally. And this group will often have a requirement to build up strength and stability around the shoulder blade and the rotator cuff muscles, but they will also often have lots of muscle adaptations that we have to try and unpick, and proprioceptive deficits, difficulties with coordination of their shoulder. And I think it's really about, it's much more subtle rehabilitation in my opinion, much more considered rehabilitation than just getting them strong, getting them to actually get back in touch with their shoulder again and control their shoulder and coordinate their shoulder and know where the shoulder is and all those things. So I think it's a really interesting group. I really like working with that group. And then if we go to the type 3 on the Stanmore triangle, which again is muscle patterning group, really. That is a group that most of us haven't got a huge amount of experience in, because we don't see very many of them. A lot of them will go to specialist tertiary referral centers like Stanmore or similar, and are in the normal outpatient clinic or primary care center or physiotherapy practice. We'll maybe see, even when I see 75% shoulders, I'll see maybe 2 or 3 of these a year, and they can be often quite different. And again, there are usually lots of other factors involved, whether they're psychological and social factors, whether they're chronic pain factors, or behavioral elements, as well as very strong muscle patterning and almost neurological presentations. And I think we have to use a lot of our broader skills as physiotherapists in these clients, and be quite innovative in how we're assessing people. And often, I think, in my experience recently, I'm starting to notice patterns of people with other sensory processing type issues, who have recurrent dislocations from this unusual type 3 group. So I think we have to be, I think, tailor the treatment very much with that group.
Okay. What about the group that isn't appropriate for physiotherapy?
Okay. Yeah. So if we're thinking about the frozen shoulders, kind of maybe the easiest decision is that if they're in very high levels of pain, if they cannot tolerate a very simple, gentle, passive stretch into external rotation, or if they're waking repeatedly in the night, their just sleep is so disrupted, I think that is quite an easy decision. If they don't have risk factors that would preclude them from having a steroid injection, I would often say, I don't think you're going to tolerate physiotherapy. I don't think you're going to like me very much if we do some stretching and mobilization, and I don't think you're going to get too much from it. Probably the best thing to do is to try and settle this down with a corticosteroid injection, come back in about 2 weeks, and we can probably start to get the movement back into it then. But that group often, I think a good group to have that conversation with. If we're thinking about the rotator cuff group, I suppose maybe the easier group to think about non-physiotherapy management would be an acute tear in a young 25-year-old, say, or under 25-year-old who has a big traumatic tear of the rotator cuff, and is probably, quite a good bet that they should have a fairly rapid surgical repair of their rotator cuff, or even other muscle injuries around that area. Pectoralis major is the other classic as well, that they really need to be operated on within 2 weeks to repair it. So they're the kind of more obvious ones. The advanced rotator cuff, the group of rotator cuff patients who have very advanced degenerative changes. So they may have been cuff deficient for a very long time. They may have undergone lots of episodes of physiotherapy, have lots of flares along the way, and over time they've developed cuff arthropathy. So they've developed osteoarthritis because the rotator cuff has not been stabilizing the ball in the socket very well. And they maybe first of all developed changes around the ACJ and changes around the head of the humerus, and then eventually changes around the glenoid. So they're the group that, you hear noises in their shoulder. They sometimes can't lift their arm past 90 degrees without very significant pain. And, that's a really difficult one, I think, because we have some great evidence in the physiotherapy literature from Bobby Ainsworth and her program, the Ainsworth program, or the Torbay program, some people call it, to basically gradually improve their shoulder flexion by using probably the anterior deltoid. I don't think it's just the anterior deltoid, but we have a nice systematic program that can get this group to a very functional level. And then we have the orthopedic opinion, which is, this group is probably for arthroplastic surgery, shoulder replacements and reverse anatomy. And there's a whole range of different arthroplastic procedures that can really improve people's quality of life, can really improve their range of motion. And, I put up my hands here always and say, again, I'm biased towards the less interventionist procedures, towards the more conservative procedures. And it doesn't take I think if you try the more conservative means and things are improving, great. You crack on with physiotherapy, and it's in a way an easier decision. But if they're just not responding to, tailored physiotherapy and the Torbay program and things, it may be a case of coming back and weighing up the pros and the cons of referring on to orthopedics. And I think it's really our role to skill ourselves as physiotherapists with what the other options are, and what they entail. If the patient doesn't know that they're going to have to be in a sling for the best part of 6 weeks, that they're going to be overnight in the hospital for, at least one night, but usually for, a few nights, and they have a husband or a wife who is, needs caring for, that have responsibilities like that. And, we have to consider all of those things and let them know the wider implications. So that's again about a conversation, I think, and us skilling ourselves up. The decision to inject or not to inject, again, I think a lot of it is about pain and ability to respond to physiotherapy. Because for me, an injection is really if somebody's in too much pain to improve with physiotherapy. But they still have to have their physio. They still need to build up the strength in their shoulder. The steroid injection is not particularly therapeutic as such. It is to create this period of quiescence when it's all calm and reduce pain, and could speed up the rehabilitation or improve their rehabilitation. And talking to the patient again about that and making a collaborative decision about that. one of the real benefits of working as an ESP, an advanced practitioner, and finding out about all of these different alternative treatments is the ability to talk about them, I suppose, with the patients, and to try and redress my bias towards conservative management. The orthopedics, I have a bias towards surgery. If you go to a rheumatologist, they're going to have a bias towards injections or, pharmacological intervention. I was trying to redress that balance a little bit and discussing with the patient and then picking what is best for them too.
Yeah, and that's important for every aspect of managing, well, any patient, working with any patient, isn't it? So always good to remember.
Yeah.
Okay. I'm aware that we've been talking for quite a long time.
Okay. I've been rattling on.
No, respectful of your time. Is there anything else that's key in managing individuals with shoulder pain that we haven't talked about today that you'd like to share?
Okay. We probably haven't touched on chronic pain very much.
Mm-hmm.
And one of the things I talk quite a bit about in my shoulder masterclass, I suppose, is trying to get away from this dichotomy between patients either have chronic pain or they have a structural mechanical problem. Okay, and I think that is something that crept in when we started to learn much more about chronic pain in the 90s, late 90s, early 2000s. We started to get a whole range of new skills to assess people who might have barriers to recovery, yellow flags, psychosocial barriers, all of that work, which is really, really useful for us. But I think my observations have been that it in a way created this, idea in some people that you have chronic pain patients and they need to be managed with hands-off and pain management and talking to them lots and a more goal-setting approach. And then you had these other patients who are, well, it's about their tendons and their tissues, and we can do techniques on them and we can do exercise to strengthen them up. And the reality is that the nervous system underpins all of this anyway. We wouldn't have pain if we didn't have a nervous system. And whether you've got a fairly acute injury to the rotator cuff or not, you still, the messages are still carried by the nervous system. The output is still in the sensory cortex. And I think we have to be aware of the role of the nervous system very much right throughout every single type of shoulder condition and physiotherapy condition that we see, and trying to integrate our really good knowledge of how to treat the tissue-based mechanical things, with things that are maybe sensitized. So I'm not sure if I'm getting that point across really well, but I think I do a neurological assessment often in people. So they might come with an acute problem in the rotator cuff, but when you really quiz them a little bit more, they've had chronic back pain for many years. They've had a whiplash injury that has given them ongoing persistent neck pain. They're hypermobile and they've repeatedly, strained their ankles. And actually their nervous system is very sensitized, really, really sensitized. And, that would, I suppose, lead me to think a little bit more about treating the nervous system as well as the tissues, and taking a much more graded approach and using a lot of reassurance, being very careful with my language that I'm using. So I think that underpins everything that we do. Pain is an expression of what is happening in the brain and the nervous system, irrespective of any tissue damage.
I mean, it's a really important consideration. Is there anything with the chronic pain patients or individuals with chronic pain? You've talked about, we need to respect the pain and treat the pain through communication skills, effective strategies like that, and treating the nervous system. Are there any other sort of like practical skills that are different with the chronic pain patients? You still give them the exercise regime, the exercise strategies, don't you, to address the underlying issues. Is there anything that's particularly different in that practical approach to managing them?
Yeah, I mean, I think that there are a few things really. I suppose I'd probably screen a little bit more for things like catastrophizing and you know, maybe do an impact of events scale if they had a serious accident, or you know, I think things like that. So maybe do a bit of wider screening to see if some of those things like catastrophizing or low self-efficacy or post-traumatic stress or those sorts of things that are important, you know, and pick up on any individual things within those questionnaires as well. I would also probably I generally take a very functional approach anyway, but I take an even more functional approach with the patients that I think have more central nervous system driven pain. So rather than kind of using numerical rating scales and being very focused on actually what level of pain, what number of pain they have, things like that, I really think about setting functional goals. I work quite closely with psychologists. You know, we have a multidisciplinary practice here, and we have 3 clinical psychologists, and we have an occupational therapist specializing in chronic pain. I've picked up lots of gems over time, you know, working with this group. You know, sometimes I find it really difficult to set goals. You're talking to them about goals, and maybe it's that it's just so difficult for them to consider being better because it's been so long since they've been well, you know. But often they can really find it difficult to get what I'm getting at. And there's various little techniques for that. There's something called brief solution focused therapy, where you ask the magic question or the miracle question, and you say to the patient, so they really can't tell you what their goal is. So you say to them, well, if I had a magic wand and I waved it over you and it made you completely better, what would you notice that was different? What would your partner notice about you that was different? Or even if you didn't even know that the magic had been done, what would be different in your life? What would you be doing? What would you suddenly notice? And sometimes that gives the 100% what they would be like if they were 100%. And then you can say, well, okay, that's 100%. That's what you notice if you were completely better. So that's maybe something that to aspire to into the future. Where are we now? We're not 0%. You're not immobile. You're not in bed. You know, you are at what level for these different things that they've identified, like walking and going back to a sport that they liked, or, you know, walking the dog or whatever it is. What level are we at now? Okay, that's 30%. So then we define what 30% is, what 40% is, what 50% is. And then we have our initial goals that we can work towards. And for me, that really works nicely for the patients that have had pain or lots of different pains for a very long period of time. There are a huge amount of different techniques. I think one of the things we talk a lot about in our clinic here is about getting people out of the threat system. You know, that, you know, often the persistence of pain and the really dominance of pain is an indication that their central nervous system is really in that threat system all of the time. And it might be coming from lots of different parts of their life. What we don't want is physiotherapy to be another threat to their system. We don't want their interaction with us to be the next threat to their system that makes them feel anxious or afraid or, you know, worried or increase or flare their pain. So really trying to create a safe space, you know, a place where, you know, they're, you know, happy, they've got time to talk to you, where you're going to listen to them, you're going to really listen to them, hear what they're saying, you know, work towards their specific goals, do things at their rate, and actually, you know, address their fears, you know. So I suppose creating a safe space for them to get better in. You need a bit of time to do that. But I suppose they're the kind of general things that I'll be thinking about.
Yeah, no, that's good. It's really good. I don't often talk to people about chronic pain, so it's actually good to go there and talk about that a little bit and find out some useful little strategies that people can use with their patients in clinics, you know, tomorrow, or just to start thinking about those things as well. So all very good and very useful. Thank you. So We've covered a lot today in this talk about the shoulder. I think it's been a really amazing overview for managing the shoulder. When I was working clinically, the shoulder was the thing I hated the most, and I think I'd be much more comfortable today having talked to you about these sorts of things just as an overview. Now, I know all of the things that we've talked about today, you run a course that's a masterclass in the shoulder rehabilitation, isn't it? Do you want to just tell us a little bit about that in case anyone is coming across you doing your course where they can go and get some practical skills and some more extended tips from you?
Yeah, absolutely. And thanks again for inviting me to talk today. Yeah, the Shoulder Masterclass is a 2-day course, usually run on a Friday and a Saturday, or a Saturday and a Sunday, but I'm open to options. And I talk about my model of shoulder problems, and it's really practical, really clinically focused. I suppose the bottom line, I even get people to write it down, is, what are the things that you're going to do differently in clinic next Monday? And I try to have everybody leaving after the 2 days with at least 5 or 6 things that they're going to do to, differently in their clinical practice. It might be just buying a whiteboard.
Yes.
That's often on the list. So we go through all of the different shoulder conditions, talk about assessment techniques and rehabilitation, and we do lots of case scenarios. And actually, probably one of the things that I have a strong emphasis on, some people recoil in horror at this, is that we do role plays, because we do a lot of time practicing techniques as physiotherapists. So much time practicing techniques when I was doing my master's, and that stood to me really well, but not that much time learning and practicing how to talk to patients. So practicing explaining what a frozen shoulder is, and then developing your own pattern. So that's the approach that I use. So yeah, I think it seems I get a lot out of doing the course every time. I find it fun. People seem to like it. And so I run maybe 7 or 8 a year. You can check out my website for details of upcoming courses.
What's the website address?
So it's www.ebtc.ie.
Perfect. Okay, I think we can leave it there today, Eoin. It's been great to talk to you. It's been an amazing overview. I think there's lots of little clinical tips that people can use there straight away, which is what we really like to do and like to share. So thank you very much for your time today.
You're very welcome. I hope people found it helpful. All the best. Bye now.